Can you see my screen?
Yes, it's good.
Okay. Thanks very much for including me in this meeting. So I thought I'd talk about how coronavirus-induced ARDS is the same or different to ARDS, and I'm going to present a couple of cases which have been challenging, and I thought we could have a discussion afterwards to see what everybody else thinks about this. Now, these are pictures are from the Worldometer, which certainly in Brisbane we were stuck to the screen looking at in the 2020 to see how many deaths and how many cases of ARDS were occurring around the world. But generally speaking, if you look at Australia, it's pretty much spared from most of the early part of the coronavirus outbreak anyway, because we were very isolated and our borders were closed. So if you notice that the graph on the right, you see that little uptick now towards the end, and that's when Australia opened up its borders. So we really didn't see much in the way of bad coronavirus ARDS until sort of towards the end of last year. And although worldwide the mortality is over 6 million, standing these pictures were taken a couple of days ago, Australia is sitting between 6,000 and 8,000 deaths, which, although below a lot of what the other world has been seeing, is still a significant number of deaths. When it comes to looking at deaths from ARDS and ventilation, it's a little bit trickier. There's not as much data. I mean, this table or graph was taken from a study, from a Dutch study, where they looked at 530 patients who were ventilated with bad coronavirus ARDS, and you look at if you look at the bottom survival curve, you'll notice that the 28-day mortality was sitting around 30%. Now, the data for Australia is a little bit harder to find, but in the Sprint-SARI database, we're probably sitting around 25 to 30% mortality. Where if you look at mortality for other sort of class of ARDS, and it's not that much different. So the literature reports numbers between 25 and 45% for other forms of ARDS. So it doesn't seem to be killing more people than we'd see before. But so my first sort of introduction to bad lung injury was really from a friend of mine in South Africa. Up until as I said, up until the end of last year, we really weren't seeing it in the ICU in Brisbane. But this was a doctor friend of mine, and he's about 55 years old, a little bit overweight, and he called me one day and said, he wasn't feeling too well, and he tested positive for coronavirus. And so I said, okay, and we'll see how it goes. And he was taking all the various anti-inflammatory drugs, et cetera, et cetera. And he slowly got worse and became more short of breath and ended up in hospital. And subsequent to that, he got more short of breath and then ended up in ICU. And in ICU, he was required high flow oxygen, up to 90%. And because he didn't want to be ventilated, he just sat through it. And he sat through what sounded like 2 or 3 weeks of hell, where he would just, any movement or anything like that, he would just desaturate. He was very short of breath, but he managed to avoid being ventilated. And after a couple of weeks, he started getting a bit better and was eventually discharged home, still requiring oxygen. And this was after, a month at least in hospital. And, but slowly got better and slowly got better. And so by January this year, he called me up again. And I said, well, look, let's, because he was feeling better. He's still, he couldn't go running or anything, but he was able to function in daily life. And I said, let's get another scan. Let's have a look. And what you can see here is his follow-up scan. So he still has some ground glass changes in the upper lobes and a little bit in the middle lobes. I haven't got the lower lobes. He already had some fibrotic changes in his lower lobes, and there's some traction bronchiectasis. So despite the fact that he was symptomatically a lot better, his lungs had been permanently scarred from the coronavirus. But more interestingly enough, were these lung function tests that I asked him to do. So if you look at the one on the left, so for those of you who don't know how to read or not familiar with lung functions, just look at the total lung capacity section, and you'll see the TLC on the left side was 40% or 45% of predicted, so significantly down. So his total lung capacity was half what it normally would be. And if you look at the graph on the bottom left, you'll see what's the typical picture of a restrictive pattern. On the right side, this was his follow-up lung function test in January, and it significantly improved. So now he's up to sort of 75% of predicted total lung capacity, and you can see his flow volume loop in the bottom left is looking much more typical looking almost normal. So, it took 6 months for these lung functions have significantly improved. And I think, to be honest, that what saved him was the fact that he wasn't ventilated. So avoiding ventilation was what kept this guy alive. Now, the next two cases are from our intensive care unit from this year. And the first one, and the reason I'm presenting them was to just highlight the difference we seem to be seeing in these patients. So the first one is an elderly lady who presented with severe shortness of breath to the emergency department. She ended up on something like 70% oxygen initially when she was admitted to the ICU on high flow. But as typical of the so-called happy hypoxic, she wasn't particularly short of breath. She didn't look very distressed, and she was texting on her phone despite the fact that she was on 70% oxygen. And she was put on some CPAP, and within 24 hours, her FiO2 had improved significantly, her oxygen levels had improved significantly, and she was down to nasal prongs, and she was discharged the next day from the intensive care unit. Now, compare that to this patient, which was admitted similarly with COVID-induced lung pneumonitis, and she was managed with a high flow and CPAP or non-invasive ventilation for about a week, but just did not improve, and subsequently ended up being intubated. And she had extremely rocky course. She was ventilated for I think in the end it was probably 10 weeks. And she'd been prone and on her back and high peeps and low peeps. But the striking thing about this case was the fact that every time we stopped her paralysis, she would deteriorate. So we'd stop her paralysis, she would start breathing spontaneously. And within sometimes hours, within days, she would start to desaturate, and she would have to be paralyzed again. And the other thing that was striking, and I've never seen this, I've been doing ICU for a long time, but I've never seen this amount of dysynchrony with the ventilator and this extreme high respiratory drive. And every time, and you could actually see the pendulum just looking at her chest. You could see how her chest was moving up and down in the opposite direction to her abdomen. And clearly this is what was causing the problem. And so she ended up on muscle relaxants for weeks and weeks and weeks, the longest I've ever seen a patient. And she subsequently succumbed to her coronavirus. Sorry, this was the CT scan 3 weeks later, and you can see there's just been no improvement at all, and possible deterioration with some of the air trapping and collapse in the bases. So, I started thinking about ARDS and coronavirus and what are we dealing with here? And went back and had a look at some papers that because that was published early on in the pandemic, and Gattinoni, was one of the first ones to recognize this, that maybe we're dealing with something slightly different in the coronavirus ARDS patients, and he proposed that what we're seeing is two distinct types of lung injury, he called the L type and the H type. And the L type was this classic low elastance, high compliance situation with low weight, with low lung weights, non-recruitable lungs. And I'll come back to histology in a moment. Whereas the H type was more typical of the ARDS that we're familiar with, where poor compliance, very high lung weights, but more recruitable lungs. And histologically, they were noting in these patients the sort of typical diffuse alveolar damage with some clot in the specimens, and which is a very non-specific sort of finding. And he went on to describe the CT scans of these patients. The A is the type L and the B is the type H. And you'll notice on the right the CT scan, the Heinz field unit. So the more blue they are, the lower the Heinz units and the more dense the lung, you see it turns more red. And clearly, for a similar PF ratio, you've got a completely different pattern of these patients. And in this paper, he talked about a couple of things, the severity of infection, host responses, all the stuff that we would be interested in. But the thing that struck me the most was this respiratory drive that they talked about, that the high respiratory drive is being responsible for some of this deterioration in the lung functions. And then subsequently in 2021, another group from Italy produced a very interesting paper where they actually did lung biopsies on the L type. Now, this was a bit tricky because these patients, they use cryobiopsies, which, if you're not familiar with, it's done using a bronchoscope, but instead of using forceps, you actually freeze the tissue and take so you get much bigger pieces, but they bleed like mad. So it was a pretty brave study. But anyway, they did about, I think, 16 or 17 patients. And what they noted, very interestingly enough, was that there wasn't much damage to the alveolar membranes. The alveolar membranes were largely intact and not particularly thickened. But what they did find was this very, very dense surrounding column of blood vessels, which were much, much more congested than you would normally see in a normal lung specimen. And they hypothesized that this was leading to quite was creating the VQ mismatch and the hypoxia that we see in these patients. And interestingly enough, and we've noticed this in some of our patients, that when you lie these patients flat, their PO2 actually gets better. Because, and the theory behind what they were suggesting was that you're redistributing blood from the lower zones back to the upper zones and improving your VQ relationship. So very different to what I'd always viewed ARDS as being. And then interestingly enough, this idea of the high respiratory drive and spontaneous breathing being bad for you, as our previous speaker talked about, was talked about by Laurent Brachard and Arthur Slutsky back in 2017. And what they showed is that if you look at these three columns, and I'm only interested in the two on the left, so the volume control ventilator is the column on the left, and then spontaneous breathing in the middle. You'll notice that although the airway pressure for patients breathing on the volume control is much higher than the spontaneous breathing, if you look at the esophageal pressure or the pleural pressures, you'll notice that there's a very negative pleural pressure on the spontaneous breathing. And when you look at the actual transalveolar pressures, they're actually the same. And they postulated that this is one of the mechanisms for deterioration in lung functions in patients with ARDS, that you get in this vicious cycle where you've got already edematous lung with impaired gas exchange with increased respiratory drive, and this high respiratory drive is leading to a patient-induced a lung injury, and really needed to be dealt with that. And this was interesting to me because up until I've been around for a long time, and when I first started working in intensive care, the mantra had always been get patients breathing spontaneous, get patients breathing spontaneous. It's good for them, their diaphragms move, and that was always our goal. And it seems that this can in fact be harmful. And you wonder that the NEJM paper published in 2010, where they looked at paralysis and improved outcomes, whether they weren't really, this wasn't one of the mechanisms that you're actually preventing this patient-induced lung injury by doing it. And ESNOD in 2020 showed something similar. So what they did is they looked at markers of excessive respiratory drive, and so the P.1 and other measures, and what they showed is that patients who were put on spontaneous breathing and had a much higher respiratory drive, respiratory effort, actually required to go back on ventilation. And deteriorated much quicker than patients who didn't have this high respiratory drive. So clearly, it's very, very significant from a clinical perspective. And these are from Gattinoni again, and he was kind of suggesting that with COVID we sort of start off with the L type on the left, and because of largely because of this high respiratory drive. This patient-induced lung injury, we are ending up with an H type and a much poorer outcome. And Tonelli, again, a very nice paper from last year, demonstrated a similar thing. And although he went on further and he said, we've got all this, if you look at the bottom of the slide, we've got all these inflammatory things taking place, but at the top, we've got patients that are, started with an L type, but and with good compliance and rapidly deteriorate with a sort of patient-induced lung injury. And then he introduced sort of the phenotype F, which is obviously the end of this process where you end up with pulmonary fibrosis and a really damaged lung. So this is my second last slide. If you look at all the guidelines from the various societies, what do they recommend? Well, they recommend, low tidal volume, fine. We've all been doing that. They certainly are very keen on proning, but that's about it. So, I thought this would be an interesting panel discussion with so many experienced intensivists to say, well, look, the society says, okay, low tidal volume and proning, but there must be a lot more to it than that. And certainly, how do we approach these different phenotypes? How do we manage them? So I've written down a whole bunch of questions for the panel, but I'll stop there and let someone else just have a few words.
Okay. Thank you, Professor White. Share your case and the questions. How about Professor Azzurri? Do you have some comment and a suggestion?
Good morning, everyone, and I'm very, very happy to be in this session with all of you. Thank you very much, Dr. White, for the excellent presentation and the discussion on whether COVID-RDS has major differences with other sources of RDS. Well, I have several questions that may be very practical. I agree with most of the things that you presented. One is I'm very interested by something that is common to COVID and non-COVID RDS. It's the PSILI, which is the self-inflicted lung injury in those patients with very high respiratory drive, where there is a very nice biological plausibility. And I would like to know whether you are successful in measuring respiratory drive in your patients, or if you have surrogate markers of respiratory drive that may help you and guide you towards a specific strategy. I found that it was quite easy in patients on non-invasive mechanical ventilation, because then we have the expiratory tidal volumes and we can expect and we can anticipate if this is too high and maybe correlate that to outcomes. However, for patients who are not on mechanical ventilation, or non-invasive mechanical ventilation, do you have any ways to measure the respiratory drive, or do you rely on the clinical examination, the respiratory rate, etc.?
Well, look, certainly, there's a number of techniques that have been described, but from a practical point of view, in the end, I think we all tend to look at the patient and try and work out what's going on. And I got to be honest. I mean, although you can measure all these things, it's from my experience, it's fairly obvious. It's quite obvious to see who's struggling and who's not. I mean, my big question is the problem that I've had, and as I said, we've had very little experience with ventilated COVID patients because, as I said, we're so far down the road in terms of the COVID itself. And you guys in Europe, you would have seen many, many more patients. Is that, it's one thing recognizing patients with high respiratory drive, but what do you do about it? And this is the thing. It's you can't keep them paralyzed forever. And once you're on a ventilator, so certainly if they're not, if there's non-invasive ventilation and the high flow, we prone them, and it all seems to help the comfort as well as their oxygenation. But once you put that tube down the throat, it becomes a much more difficult situation.
Well, that's true. So still, I believe that the future trials in the use of NIV in patients with ARDS will have to take into account the expiratory tidal volume. And many of the experts in the world, and there are these controversies about whether we should measure the expiratory tidal volumes and take it into account. But to optimize NIV, I think there are settings that we need to take into account. But we can also anticipate maybe that failure of NIV and maybe get the patients to early intubation, because there are data showing that early intubation might be associated with better outcome. I must say that for now, we didn't translate these observations into clinical practice, but this is something to discuss.
Yes, I do agree with Professor Azoulay. We have the experience, but 2 years ago, that's have very many severe COVID-19 ARDS patient, and we observed the driven pressure through the minute volume and the tidal volume during the NIV or high frequency nasal cannula. If the patient not so good response to this kind of non-invasive respiratory support, we will intubate the patient very early. That's control the driven pressure and to decrease the silly kind of death. And the sedation and the paralyzed for this kind of patient during that time.
Dr. White, I have a question for you on, now we are using a certain number of monoclonals and antivirals, to shorten the time on carrying COVID-19. Well, the 3 cases that you presented were very interesting, and I'm very interested by the protracted course of COVID-19. Was the second case in the elderly lady that finally made it without intubation, was she having a protracted course of COVID-19? Was she still remaining positive with SARS-CoV-2 over the time?
Do you mean, was she still positive from her things? Well, look, we don't, as a rule, I mean, the guidelines change all the time. And they do not, they don't clear patients based on their positivity anymore. So our infectious disease department often will say, after 2 weeks, even if they're still positive, that they're not longer infectious. The last case I presented, interestingly enough, she was, as I said, she was about 10 weeks. She was still, we did test her, and she was still positive on PCR after 10 weeks. So, she wasn't being isolated anymore. We'd had her in the general ICU environment because she was considered to be non-infectious, but yeah, she was still positive.
I think that's another target for thinking on how to ventilate these patients, because we have seen immunocompromised patients with bearing SARS-CoV-2 for weeks. And they were able to, to improve not only imaging, but of course also clinical status only once the virus was either decreasing, moving from 20 to 30 PCR cycles, or completely cleared. So we are now having strategies to help clearing the virus in these either elderly or immunocompromised patients with protracted COVID-19 courses.
So what is your strategy for this?
I'm sorry, I didn't catch the question.
Sorry, so you say you had a strategy for clearing prolonged infected cases. What do you do?
Yeah, none of the strategy that we are using is, high level of evidence. So it depends where we are. So we are either doing monoclonals for a certain number of patients, and this is in the setting of the recovery trial. We are also having convalescent plasma, but as you know, all the trials are negative. So we are using it only in patients who are immunocompromised with a B-cell depletion. And sometimes we are thinking on, maybe managing dexamethasone and steroids differently as to avoid having a protracted COVID-19 course. But still, for now, we are only using strategies that have a very low level of evidence. There was a very interesting question in the chat for you, Dr. White, on whether you were able to recognize H and L phenotypes clinically.
Well, I think, interestingly enough, those two cases I presented, the last two were a very, very good example of the two different phenotypes. The classic thing that you see is what they've been calling the happy hypoxic. So the classic L phenotype is the patient that comes in there, is very hypoxic, but respiratory rate maybe 20, 22. The CO2s are fine. They're sitting. I mean, I always say they're cell phone positive because they sit on their cell phones and they're texting all day long while they're sitting there looking at you, and it's quite disconcerting when you look at their gases and you think, wow, this is terrible, and yet they look perfectly fine. But what we've noticed is that the ones that sort of so they either get better from there and they're fine, and that was a lot of them did that, but there seems to be this group that just slowly gets worse and worse and worse and worse. And that last case was the one, as I said to you, that was the one that was, she was on non-invasive for a week, but just basically got tired. And in fact, we had her on non-invasive with nitric oxide. We've been trialing nitric oxide through non-invasive, either high flow or the non-invasive ventilator, which worked quite well and certainly improves their hypoxia, but obviously it doesn't do anything for the actual mechanics. But the frustrating thing with her was when she was ventilated, even though she should be able to wean her oxygen, we could not get on top of this high respiratory drive. And there was just no way, doesn't matter what kind of mode of ventilation she was on, it could not get that respiratory drive under control. And there's been some, there's some papers looking at APRV and maybe, higher PEEPs will reduce the respiratory drive, but it certainly didn't help in her.
Yes, I think if the patient, the lung is not a response to the recruitment maneuver, maybe the APRV is not good for the patient. Yeah.
Yeah, I really agree with you.
Mm-hmm.
That is correct. I mean, this what I presented is just part of a much longer presentation I did at the ANZIX meeting a couple of weeks ago, and I reviewed APRV, the evidence for APRV in COVID, and there's none, obviously. They're very small studies, and in fact, the group in Australia that is that does most APRV is in the Western Australia, in the Perth. They're very keen on APRV, and they did a small study and showed that the mortality was actually it was a retrospective chart review, and so it's not high quality, but they certainly showed worse outcomes in the APRV group.
I have a question to the Professor Azole. How about the patient, COVID ARDS patient, they have the pulmonary fibrosis? That's what kind of fibrosis is that can recover for your experience?
I think that we have data on patients who are very mild. We've met very mild ARDS when you follow up over the time. As mentioned in the first case, we might have clinical abnormalities, we might have physiological disturbances, we might have ground glass opacities, but when the ARDS was mild, it's very hard to get to fibrosis after 6 months. So when you follow the patients in outpatient clinics, they are fine. The problem with fibrosis is mostly in two different cases, and one is when the patients are in the ICU, ventilated for a long time, and having a fibrotic evolution of the ARDS. And the other one is when they have an organizing pneumonia after ARDS and they might receive another course of steroids. So the management is quite the same in the two. So what we do is that we are making our best to rule out any infection. And for some patients, only the 1 or 2 courses of steroids in the ICU might be, the bed for COVID-19 associated aspergillosis. So we are very much looking forward to rule out any kind of infection. So this is the first setting. And in the other setting, we are trying to document an organizing pneumonia that might be sensitive to another course of steroids. But for now, the patients who are extubated and weaned from mechanical ventilation, and when we follow them over time, lung fibrosis is a very, very rare pattern. So we are only getting that in the patients who cannot be weaned from the ventilator. And I would say that that's very close to what we see outside COVID-19 ARDS.
The previous presenter, I thought was very interesting in terms of where he mentioned the mucus plugging that occurs in these patients, and the guys in South Africa published a while ago on this where they actually went and bronched these patients, and the mucus load was very, very high. Do you advocate bronching these patients and trying to get some of this mucus? Is at any point?
Yeah, we did have this experience. I would say not quite often, but this happened. It also happened that the patient had many different courses of steroids over time, and they have been responsive to that. And as you know, there are also patients who went to lung transplantation, and some of them are quite doing well. So I think that the question of assessing the reason for non-improvement or deterioration, even when they have features of pulmonary fibrosis, is very relevant as for other RDS patients.
Thank you. Thank you for sharing. And Dr. Huang Xu.
Hi, Dr. White and Azuli. Thank you for your presentation and discussion. I think I learned a lot because from 2020, I didn't have any chance to manage any COVID-19 patients. So it is brand new for me to learn about the experience from the clinical practice. And I think I have several questions. First, the Dr. White had mentioned that Dr. Gattinoni had proposed two subgroups for COVID-19 ARDS, which is subphenotype L and H. And there's much difference from the clinical manifestation to the pathophysiology and also the mechanical ventilation strategy for such patients. And I've learned a lot, but I don't think the subphenotype is unique for the COVID-19 patient because in my clinical experience, I think I have treated, although not so many, but several patients who had the same or at least similar clinical manifestations and radiologic findings as the L subphenotype. And I think maybe I think the target, the aim of the subphenotype is to differentiate the different strategy for such patients, especially mechanical ventilation. Because if you face a patient with L type and you didn't know if you didn't know it is COVID-19 patient, and you would say, oh, the CT scan is not so bad, and the compliance is okay. So maybe you would not use the higher PEEP, and you would use the maybe a higher tidal volume. So I think if there are any other significance for the subtyping COVID-19 ARDS, or we should use the basic rules for ARDS. That's the first question. Also, there are another question because you just mentioned about happy hypoxia, and I heard from my colleagues back from Wuhan, and they told me that many patients with severe hypoxia, they didn't have the increased respiratory rate, but there's a point that the patient will deteriorate sharply and be ventilated, be intubated and ventilated. So my question is the patient's situation deteriorate suddenly or gradually? And could we have some signs of deterioration for such hypoxia patient? And should we intubate such patient earlier to decrease the mortality? Thank you.
Look, I'll take the first part of the question, and I'll let Dr. Azoulay answer the second one because he's seen a lot more than I have.
Yeah.
Look, you've got to remember, and this is why I brought this up in the first place, was that there's never been so much interest in ARDS as there is now. Okay, and so what I've been trying to clear in my mind is it just now that we're examining ARDS so carefully that we're seeing all these different patterns, and is it that in the past when ARDS studies were running, there really wasn't as much sort of global interest in this, and I have wondered that, and it is true. There's nothing that you can actually pinpoint that is unique about coronavirus ARDS. That you might still see in ARDS from any other thing. And remember, ARDS is a syndrome. It's not a disease. It's not a diagnosis. It's a syndrome. So, and also, remember, people have been trying to classify ARDS for many years. The primary ARDS, secondary ARDS. There's been all these classifications which haven't really stuck around. So, but having said that, though, I still, just from my own limited experience, these patients do behave slightly differently, and they don't respond to, and I've sat through a lot of pandemics. I mean, I was for SARS-1, and I've sat through swine flu and H1N1 and all these different pandemics, and these patients seem to behave a little bit different. And the one thing for me that's been the most impressive part is this. First of all, the happy hypoxic thing, which you can see in other patients, but it doesn't seem to be as obvious. And the other thing is so that's the L type, and this very high respiratory drive. I haven't seen this, and I've seen a lot of patients with ARDS, but the extent of this respiratory drive is something impressive to me, and I'm not sure whether Dr. Azoulay would agree, but it's just stuck out in the patients that I've seen. But I'll let him speak to the clinical stuff.
Well, I would say that I do agree with what you said. You just raised a very, very important question, is about the threshold moment of intubation in hypoxemic patients overall, in ARDS patients in particular, and in COVID-19 ARDS patients specifically. I think that there is some evidence that delaying intubation until very late might translate into more morbidity. And this evidence is quite limited because there are controversial data, but we need to take this into account. That being said, transitioning ventilation or oxygenation strategy from high flow NIV / to intubation cannot only depend on the respiratory rate or only on hypoxemia. As you know, there are three different clinical vignettes that have been implemented. One is proning in patients who are spontaneous breathing. And I think that it's not, you can prone a patient who is on spontaneous breathing. The results are quite surprising. There is an improvement in PF ratio. There are data showing that there is also an improvement in physiological parameters. And the other thing is there are data that translate this into clinical outcomes. So for now, we have sufficient data to recommend prone positioning in patients who are in spontaneous breathing with COVID-19 ARDS, and there is an extension in other forms of acute hypoxemic respiratory failure. So this is something that we need to take into account. The second thing is, in my experience, I would not consider the same way patients who are very shortly after symptoms onset. So they have the viral pneumonia the first week after they have symptoms onset. Then patients who are doing the day 8 rebound, inflammatory rebound, where they are coming only 8 to 10 days after the respiratory viral onset. Because we know that the pathophysiology might be different. We also know that the therapeutic targets are different. I would be very, very anxious to do steroids without antivirals in the first week, and very careful. I would be very careful also to manage the patients the same way for the second week. For the first week, I don't think that we have the opportunity to wait for mechanical ventilation, because we know that this patient will also deteriorate when they will reach day 8, day 10 with the inflammatory rebound. When the inflammatory rebound is behind you, so then you might consider waiting a little bit using high flow oxygen, or for those who are using CPAP or pressure support, they might be using it. But as you know, here again, there's a little matter of controversy. And the third thing is about the type of patients. You said that you didn't get patients with COVID-19 since 2020, which is, I'm very, very happy for you. It's a miracle. I can tell you that today we still have COVID-19 patients intubated in our ICU. For one reason is that we are the reference center for immunocompromised patients. So for these patients, we are really doing our best to avoid, delay, or make everything that would avoid mechanical ventilation in these patients. So we might be using NIV in very specific setting of obese patients, or when there is a hypercapnia, or when there is an associated part of cardiac pulmonary edema. Otherwise, we would stay on high flow oxygen. But even on high flow, you might have seen the paper published in Thorax by the Italian group showing that high flow oxygen in the setting of COVID-19 might be less effective than we can see elsewhere. So I didn't answer your question directly, because I think that there are many different clinical boxes to put in the clinical reflection. So this is one. And two, I think that there are many confounders, and we have a menu rather than a strategy, and we need to apply the menu according to the clinical situation.
Thank you. And would you try prone position for the high flow patients, or for most of them, or even every one of them, if they had a severe hypoxemia?
Well, I must say that there is another confounding factor, is the surge and the number of ICU beds that we have. For now, there are countries where high flow oxygen is used either in the emergency department or the wards. It's very complex because we have a huge nurse shortage, making that we cannot add a strain to nurses in the wards, and we don't use high flow oxygen in the wards. So I think that the surge is another confounding factor, making that we might be using high flow oxygen even in some patients in whom standard oxygen could be enough, or could address the clinical question. If the question is, I have enough beds, and should I use high flow oxygen in every patient before intubation? I would say for now, yes, because of the entire experience that we have and the data in the literature. But I could also argue for not using it, but for now we do it.
Thank you.
I think one of the very frustrating things that I've found about dealing with this disease is that you've got to think very long term, and often strategies that you use that seem to work in the short term end up killing the patient. So as we were talking about earlier on about spontaneous breathing, I mean, spontaneous breathing, often when you put the patients on breathing spontaneously in the beginning, the oxygenation actually improves, because you start to recruit. Your diaphragm's working, you're starting to recruit lower lobe alveoli, and your VQ relationship improves and your PO2 goes up, only to then fall apart in a couple of hours or a couple of days later. So it is a difficult disease to treat, and there's all these different phases of the disease, as Dr. Azole was pointing out, that may need different management at different times.
Yeah. Okay, thank you. Thank you all the experts here, and we discussed the case, but the time is fly now. We should complete this session. Thank you so much for all your sharing. Thank you.